11% of the gross hematuria will have bladder cancer, 1.5 of the gross hematuria will have renal cell carcinoma. The minority, about 0.8, will have only upper tract transitional cell carcinoma. We have to know, we have to recognize the patients with hematuria even if they are a recipient of anticoagulants or antiplatelet. They also deserve further investigation. This is for the gross hematuria. Now for the asymptomatic microscopic hematuria, the prevalence of asymptomatic microscopic hematuria in general population is 2.5 in men and from 8 to 11% in women. Overall, urinary tract malignancy rate in patients with asymptomatic microscopic hematuria is 2.6. And the bladder cancer is the most common detected in around 4.8, followed by the renal cell carcinoma, and the rarest in asymptomatic hematuria is upper tract urothelial carcinoma. We don't have a solid definition of asymptomatic microscopic hematuria. As you can see in the table on the left side, you will have different definitions of asymptomatic microscopic hematuria. The EOE said you must have 3 RBCs in one test. The American College of Physicians, again, 3 RBCs in one test. Canadian, 2 RBCs in 2 consecutive tests. The NICE guidelines or the UK guidelines, you must have RBCs in 2 of 3. So we don't have a solid definition of microscopic hematuria. Even Japanese say you must have more than 5 RBCs in high power field in single urine analysis. But we have to recognize that we have a common risk factor. If these risk factors are present in patients with microscopic hematuria, you have to raise the alarm to look for malignancy. Male, gender, age above 35, history of smoking, occupational exposure to chemicals, analgesic abuse, history of gross hematuria, history of pelvic radiation, history of chronic infection, and a history of exposure to non-carcinogen or chemotherapy, history of chronic indwelling catheter predisposed to malignancy. Here are the guidelines from the EOE. Sorry. We have to exclude first the benign causes, then to go for further urological evaluation. Microscopic hematuria that occur in patients taking anticoagulants again must go for further evaluation. For the urologic evaluation of asymptomatic microscopic hematuria, cystoscopy should be done in patients older than 35. Persistent hematuria with negative urologic workup necessitates further follow-up by regular check. Upper tract imaging, we have the AUA guidelines recommending a CT contrast study as the gold standard for investigation of any patient, even with microscopic hematuria. However, recent modeling study evaluated the potential implication of replacing CT urogram with ultrasound, demonstrated that ultrasound plus cystoscopy would be more cost-effective than other options, and they're nearly the same diagnostic yield as CT. So the trend now to replace the CT and the initial workup for hematuria by ultrasound and cystoscopy. Then according to the ultrasound, we may need a CT, of course. This is the imaging recommendation from different guidelines. If we have a concern about the CT as the initial workup, there's a major difference between guidelines, as we will discuss. We have a higher radiation dose. We have debated benefit and benefit harm ratio. We have debated benefit cost ratio, And there is emergency risk stratified approach, which we may adopt and we may use in our patients. So we better select patients indicated for CT. If you look at the AUA guidelines, they have an age threshold of 35, and they recommend CT for all patients. The Canadian, they have age threshold of 40, and they leave the choice of imaging to the surgeon, CT, MR, or ultrasound. The British, from 30, they didn't specify, but they specify just imaging. The European do not specify age or imaging modality. And here are the recommendations of the European Association. First of all, take a patient history focusing on urinary tract symptoms and hematuria. Use renal and bladder ultrasound and or, so it's according to your decision, and or computed tomography, intravenous urography during initial workup in patients with hematuria. Once a bladder tumor has been identified, the next step is to do CT urography in selected patients. NICE guidelines in 2015. So urological investigation must be tailored according to the patient age and symptoms. If he is above 40 with visible hematuria, you have to do urgent CT, cystoscopy, and cytology. If he is below 40 with visible hematuria, you just need an ultrasound followed by CT-QB, cystoscopy, and cytology. If he is above 40 with microscopic or non-visible hematuria, just do CT-QB followed by ultrasound, cystoscopy, plus or minus urine cytology. Below, with microscopic hematuria, do ultrasound renal tract alone, and with cystoscopy for symptomatic cases only. The next point is urine cytology. Urine cytology is recommended as an adjuvant tool. It's not the initial, it's not the whole diagnostic procedure. And we don't have a consensus among the guidelines regarding the inclusion of urine cytology for the diagnosis of cases with microscopic hematuria. You can see in the AUA guidelines, the statement that the use of urine cytology and urine markers is not recommended as a part of routine evaluation of asymptomatic microhematuria with grade of recommendation C. In the European statement, they recommend the use of voided voided urine cytology as an adjunct to cystoscopy to detect high-grade tumor with with very good strength. They recommend to perform cytology at least 25 millimeters of fresh urine with urine morning sample is not suitable because of the frequent presence of cytolysis, and they recommend the use of Paris system for cytology report. These guidelines and these classic teaching have been debated in many trials. Recently, we have the DETECT-1 study and we have the IDENTIFY study, and I'll focus on the DETECT-1 study. The DETECT means detection of bladder cancer using the Euromark test. This is the test that have been studied for the hematuria patient. This prospective observational study, recruiting patients 18 years old and older, following a presentation of microscopic or microscopic from 40 hospitals, and all patients underwent cystoscopy and upper tract imaging, ultrasound or CT or both. We have more than 3,500 patients with microscopic hematuria. We have patients, most of them underwent ultrasound, a good number underwent CT, and minority did both ultrasound and CT. What about the results? Malignancy detected. Overall, the incidence of urinary tract malignancy in patients with hematuria is 10%. 8% in bladder cancer, 1% renal cell carcinoma, 0.5% upper tract. And as you can see, the macroscopic hematuria, there is higher incidence of detection of the malignancy. In bladder, 11% bladder cancer in macroscopic, 2.7 in microscopic. Upper tract malignancy, 2.2 in macroscopic, and it is very rare, 0.4 in microscopic. In microscopic hematuria, they didn't detect any urothelial carcinoma of the upper tract at all. And this is due to the rarity of the pathology. When they compare the ultrasound and the CT in their sensitivity and the predictive value in their predictive value for detection of malignancy, and they stratified by upper tract and the bladder cancer. In upper tract, we have very low detection rate, even by ultrasound or by CT, maybe very low in CT. In the bladder, both are high, but of course the CT have much higher detection rates. So CTU can be safely replaced by ultrasound in patients who have microscopic hematuria, and the incidence of upper tract urothelial carcinoma is very low in macroscopic and almost nil in the microscopic. Patients with suspected renal calculi require non-contrast CT. So at the next step, imaging cannot replace cystoscopy to diagnose bladder cancer. These are the conclusions. Another study from my clinic in 2013 about using hematuria risk index. So it's a stratification tool utilizing clinical parameters to calculate the risk of malignancy in patients with gross and microscopic hematuria. They give points for each of the risk factor. They give 4 points for gross hematuria, 4 points for age above 50, 1 point for positive tobacco history, 1 point for male gender, and 1 point for RBCs above 25. And they calculated the overall risk. If the patient have very low risk, if they score from 0 to 4, with a detection rate of cancer from 0 to 0.3%, if the patient have a total score from 5 to 8, he is in moderate risk, with a detection rate from 1.1 to 2.5% chance of having malignancy. We have the high risk group scored from 9 to 11 points with very high chance of malignancy from 10.7% to 11.6%. They said, according to their stratification, that low risk group needs no further evaluation. Intermediate risk group needs ultrasound and cystoscopy. High risk group need CT, enhanced CT, and cystoscopy. So they spare the CT for the high risk group only. Next, we'll go for the resection for the TURBT general recommendation. For doing a good assessment of a bladder tumor, you have to follow the general recommendation, like the bimanual examination, endoscopic inspection of the urethra, bladder mapping, don't miss the bladder neck and the anterior bladder wall, complete resection of the tumor, deep resection down to the muscularis layer. In block resection is an alternative whenever possible. Full hemostasis is recommended and is a must. If your assessment of the bladder of the tumor as superficial, consider mitomycin installation. And the urologist assessment during cystoscopy is very strong and very high, with very high sensitivity. The urologist can take from the cystoscopic look the tumor is invasive or superficial. So it is very trusted. Here are the guidelines from the European TURBT guidelines. Again, perform in block resection or resection in fragments. It's according to the surgeon preference. The most important is to remove the whole tumor with a deep layer. During follow-up, if you have a TA tumor, you can spare the muscle layer. Second, TURBT is very important in the following situation. You have incomplete initial resection, if you have no muscle in your specimen, and in T1 tumor. It's important to register the result of a second TURBT as it reflects the quality of the initial resection. The EOA guidelines for the TURBT: at the same time of resection of suspected bladder tumor, a clinician should perform cystoscopic examination of the anterior urethra, again, bladder, and should be documented. He should document the size, the location, the configuration, the number, the mucosal abnormalities. At the initial diagnosis of a bladder cancer, a clinician should perform a complete visual resection. Complete resection is very important whenever possible, when technically feasible. And this is a clinical principle from the AUA guidelines. Again, in a patient with a history of non-muscle invasive bladder cancer, this is a regular follow-up with normal cystoscopy and positive cytology. A clinician should consider prostatic urethral biopsy, upper tract imaging, as well as cystoscopic techniques to improve visualization, like the blue light cystoscopy when available, ureteroscopy, or random biopsy. For the prostatic urethral biopsy in patients with positive cytology, you have to take a biopsy from any suspected lesion in the prostatic urethra, and you take from around the verumentanum biopsy from each side. At the time of each occurrence or recurrence, a clinician should assign a clinical stage. You have to reassign the clinical stage in every time, and classify the patient accordingly as a low, intermediate, or high risk every time. Examples of missing urethral tumor and missing anterior wall tumor. If you skip mapping of the bladder and the visualization of the urethra. Staging, we all know the staging of the non-muscle invasive and the muscle invasive bladder cancer. This is according to the 2017 TNM staging. The grading, we have two systems of grading. The 73 grading system as G1, G2, and G3. And we have the 2004 WHO grading system as papillary lesions with low neoplastic potential, and high grade and low grade. We have two systems for grading of the tumor. According to the European Association of Urology, the recommendation is to use the 2017 staging system, the TNM staging system, and they gave the pathologists the options to use the 2004 or the 1973 WHO grading system for histological classification. Because the 2004 is only for the papillary lesion. So you need the 73 for the flat lesion. Then the European guidelines, they insisted that we don't use the term superficial bladder cancer. And they said we have to mention the stage and the grade whenever the terminology of non-muscle invasive is used. In the American, in the EOA guideline, they recommend using 2004 WHO grading system over the 1973 WHO grading system, unlike the European system. Very important, the variant histology. If you have a dedicated geopathologist, he can look in the specimen and he can easily detect variant histology. And here is the AUA guideline statement. An experienced genitourinary pathologist should review the pathology of a patient with any doubt in regards to variant histology, like the micropapillary, like the nested, plasmacytoid, neuroendocrine, sarcomatoid, extensive squamous or glandular differentiation, or the presence or absence of lymphovascular invasion. This is very important because once you have variant histology, you don't lose your time in PCG, you don't lose your time in follow-up, you have to consider immediate cystectomy. So once you suspect variant histology, please consider review by an experienced genitourinary pathologist. Most of the time, we need a second TURBT. If you have a residual tumor, if you are missing a muscle layer, if you have a high-grade or T1 disease. We do it 6 weeks after the initial resection, and we must include the resection of the primary side in our second look. The evidence, why we need the second look? Because in residual tumor is seen in up to 50% of cases. Under staging, if no muscle included, if you miss a second look. If you do a second look, we will have 25% upstaging, 30% will, of the cases, second look will change the treatment protocol and the management protocol, and definitely second look TURBT will increase disease-free survival and decrease recurrence in up to 20% in 5-year disease-free survival. Type of cystoscopy. Of course, we use the white light cystoscopy, but we have a certain variables, certain types of cystoscopy, like the blue light cystoscopy, which uses the dye 5-aminolevulonic acid LAA in installation, and is been approved by the FDA for the follow-up, for the surveillance of the bladder cancer. And the EOA recommends against, so you don't use blue light cystoscopy for the initial evaluation of microscopic hematuria. You may use it later, but it is not recommended to give a patient injection for his initial TURBT. The narrow band is an alternative endoscopic optical image enhanced technique that enhance contrast between the mucosal surface and the microvascular surface without using a dye. So because we don't have a dye, so we are free to use it if available. So narrow band imaging and the white light cystoscopy achieved a similar overall 12 months recurrence rate, but narrow band imaging assisted TURBT significantly reduced the recurrence rate. So if available, it is an option to use it. Unlike the blue light cystoscopy, you cannot use it in the primary TURBT. To make a decision on the proper management, we have to do risk stratification. The recurrence and the progression probability rated depends on several clinical and pathological factors. The ability to stratify patients based on this factor is important to be tailored, is important to tailor the treatment protocols. We have different stratification tools. Here is the AUA stratification into 3 groups: low risk, intermediate risk, and high risk. Of course, in every stratification system, you will find low risk is low grade tumors, less small tumors, solitary, and maybe low malignant potential. In the high risk group, you have the high grade T1 tumor, recurrent tumor, multifocal tumor, carcinoma in situ, BCG failure, variant histology is high risk in the AUA, and very high risk, or the highest risk in the European. Any lymphovascular invasion, prostatic involvement is considered high risk. Intermediate risk is something in between the high risk and the low risk. We have the European risk stratification, the same low risk, intermediate risk, and the high risk, but they have a subgroup, what we call highest risk tumors. These tumors are even T1, G3, high-grade tumor associated with concurrent carcinoma in situ, multiple and or large tumor T1, G3, high-grade and or recurrent T1, G3, associated with carcinoma in situ in the prostatic urethra. Some forms of variant histology of urothelial carcinoma and lymphovascular invasion. Those are considered the highest risk category. So unlike the high risk, we don't spend time in BCG installation. Those group, we need an immediate cystectomy. We have a risk calculator coming from the EORTC. It's very useful, and it is depending on 6 factors: number of the tumors, size of the tumor, recurrence rate, T stage, grade, and carcinoma in situ. They give a score for each point, and at the end of the entry, you will have the score, the EORTC bladder score. We have 4 categories. Scores is correlated with the recurrence rate at 1 year and 5 years, correlated with the progression at 1 year and 5 years, according to this score. Very useful. Residents can use it. They have a mobile-friendly application to calculate the risk, and they have a computer-based application software to calculate the risk. Of course, it is very recommended. In patients receiving BCG, we can do the EORTC bladder risk calculator. However, we have from the Spanish Urological Oncology Group, we have the CUETO risk calculator, which should predict the risk of recurrence and progression for BCG treated patients. So in BCG treated patients, we adopt the CUETO risk calculator, not the EORTC calculator. And it is based on 7 items: sex, age, recurrence, number of tumors, T stage, carcinoma in situ, and the grade, of course. Here is the CUETO risk calculator: gender, age, recurrence rate, number of tumor, T stage, associated carcinoma in situ, and the grade. And they give the score for each point of these 7 points, and they give and they accordingly you will predict the recurrence and progression, and we can decide the treatment. Finally, to conclude, proper diagnosis and stratification is the cornerstone for the management of bladder cancer. The risk of upper tract urothelial carcinoma in patients with microscopic hematuria is extremely low, and renal and bladder ultrasound can identify both parenchymal cancer and bladder cancer with high sensitivity. And we leave the upper tract carcinoma if there is a high suspicion for the CT with contrast and or ascending study. The use of CT urography should be revisited by weighing benefits versus risk, and CT urography protocol should be optimized to radiation dose, because as you know, CT urography radiation dose is almost 400 times the chest X-ray. We still have a very strong role for the role of cystoscopy to diagnose bladder cancer. Cancer remains the gold standard. Thank you.